Thank you, Kavehi, and to the organizers, including KJ, for asking me to come and share some of my passion for neuroscience with you today. So we're going to go through Name the Lesion, and KJ knows that I love to kind of torture the nurses and the residents and trying to figure out where the lesion is. In my day, when we learned neurology, you weren't allowed to look at the imaging until you could figure it out. So it's looking at the brain, and part of the interesting thing about being in neuroscience is that you can figure out, because of the way that brain's organized with the road maps. This is a road map of Hawaii, and around here usually it's red, but this is green. But there's road maps that help us follow what's going on with the patient. So some of this is going to be obviously a lot of review for you experienced nurses, but I thought that it's always kind of fun to bring it back to that baseline. So going back to the homunculus of how our brain is organized. We know that there's the area that's the sensory, which is in the posterior parietal, and then the motor, and I always think of it motor forward. So before the presylvian fissure here, the motor area, the motor strip runs in front of the sensory. So the motor, and thinking about how we organize this, helps you decide where the lesion is. So we know that the leg, the homunculus again, is dangling down between the two hemispheres. So if you have, say, hydrocephalus that's stretching those fibers, that you'll have patients that have leg wobbliness. And then the trunk is a smaller area of both our motor and sensory. And then, of course, our hand is very large and drapes over the part of the homunculus, so lying on this part here. And in the motor areas in the frontal region. And then our thumb is obviously a very large motor area. Our forefinger is a very large sensory area. And then the face dangles down in the lower part. So the face and, of course, the tongue and the ability to move our tongue is going to be very important. And then, and here's the tongue here. So, and then the sensory again follows similarly. So it's really helpful to know when we talk about different areas of stroke, for example, where you have maybe the anterior cerebral artery, and we'll talk about that, where the leg weakness comes because the anterior cerebral artery is lost. And the anterior cerebral that comes up and feeds this part of the brain, and the middle cerebral artery, there's an interesting phenomena where if you have watershed, like loss of blood flow where it's decreased, so meaning where the ACA is coming up and the MCA is coming up, there's a watershed. So your watershed is going to be losing this area here, so you get what we call a man in the barrel syndrome, where it's like a man who's in a barrel who they can kick their legs because this homunculus part is working, and they can move their fingers because this part of the homunculus is working, and their face, but they can't move their trunk. So just knowing these kind of things, it makes it very interesting. And this is again showing, again in a cartoon fashion, our motor function. And again, our hand skills, the neck, the arms, the fingers, the face down here, the sensory that's just behind there. And then when we're describing strokes and injuries to patients, tumors, we can tell them that there's speech areas that we all know, the speech of the Broca's, and then the Wernicke's area of language, and then hearing that is in there. We'll get back into this in a little bit. Our frontal lobes, when we have patients with traumatic brain injury, we know that they strike the front of their head. So the thing that we know that's going to be affected is their personality, their mood, initiative, so the ability to be interested in doing things. So if any of you have seen the One Flew Over the Cuckoo's Nest, where Jack Nicholson had bifrontal lobotomies, and that's how they used to treat very recalcitrant psychiatric patients, he just sat there. He wasn't interested in anything, though he had all his motor movements and vision. His initiative and interest was decreased by that. And obviously our concentration, our behavioral skills come from there as well. And then we know that the temporal lobe is our memories, our emotion, the limbic system that runs through there. And the vision, though, coming through the eyes, we know those motor tracks, and we'll get to that, get to the posterior occipital region. And then the cerebellum, as we know, is our posture, our balancing, coordination that we can do very well without, but don't do well with the brainstem compression that might happen from a cerebellar stroke. So again, localizing lesions, it's going to be important that you know which side of the brain does different things. So our dominant hemisphere, for those of us who are right-handed, about 95% of us are going to be left hemisphere dominant. That's going to be our spoken language, our ability to obviously move that right side on both arms and legs and hands. So I like to think of it, the R's, the reading, writing, arithmetic. So numbers and the ability to do math is going to come from that. that, as well as your reasoning. So written language, scientific, all comes from that dominant hemisphere. And then we know that that's what's going to be affected if someone has a dominant hemispheric lesion. And when you have the non-dominant hemisphere, you can tell patients or families that probably they're going to lose some artistic ability, their ability to do spatial things. So be able to find their way to the auditorium or to the bathroom. Once you've been there, you would lose your way because you can't find that spatial area, or that spatial orientation. And then our art and awareness and creativity and music comes from that side as well. So I'm going to back up a little bit. Excuse me. So we talked a little bit about Broca's, the frontal area, the speech production. And again, experienced ones know that. And again, I think of it motor forward. So motor forwards, the frontal lobes, and also being able to generate that speech, the motor being able to say the words. So it's producing the speech. Someone has an area where their frontal area is, an injury where their frontal area is not working, they're going to have problems generating those words, getting the words out, but fully understand what you're saying, because the ability to hear and understand is going to come from that temporal region. So think of it, I'm very visual again, so I think of it as your ears are where you're hearing something and being able to decode it. So when you have a temporal lesion, or I'm pointing at the wrong hemisphere, for me it would be the left hemisphere, the left temporal lobe, then I would have problems if there was injury there. When you talk to me, and what I tell families is it's like you're speaking a different language. If you're not Russian, it'd be like speaking Russian to them. They just find more Swahili. It's just words, it sounds like things. The content of emotion is there. So if you're crying or it sounds funny, they might laugh, but the actual comprehension of the words are not there because it's going through that temporal lobe, the hearing area. The Broca's area, again, is motoring out those words. So if you have a frontal lesion, you're not going to be able to say the words, but your temporal region, if it's not affected, you'll be able to at least understand. So as you know, we'll tell people, when we're doing our exam, I always tell the new residents or our new nurses, don't show fingers, and we don't squeeze hands. So squeezing hands can be, of course, a grasp reflex. What we do is say, show 2 fingers, and kind of sometimes when you're first learning, kind of have to hold your own hands here, because otherwise you might have that tendency to mimic or show fingers, and they're mimicking you. So it's really important that we teach people not to move their hands and be able to just ask and see if they can understand. If they can understand, then their temporal region, Wernicke's is working, but Broca's is not. I'm not going to go through the pituitary gland. We all know it's there, and we know that for us, at least in the neuro ICU, we're really very interested in whether the patient has, if as they progress to brain death, they may have decrease in their antidiuretic hormone and have loss of urine, very dilute urine, and their sodium may climb. I'm not going to get too much. We know that the gray matter is the area that has highest energy. They have the cell body, so when we have patients who have a noxic brain injury, the area that they're going to lose is the cortex and the gray matter that fuels us and has the ability to have the cognition. The white matter, the axons or crossing of the axons, these are where we have problems with axonal injury when there's injury from, say, traumatic brain injury, and then multiple sclerosis is affected there. Now, I mentioned a little bit our cerebral vasculature. So again, reviewing for you folks and describing it to patients, families, I always remind them that there's 4 blood vessels. We all know the 2 carotids that run up front, but there's also the 2 in the vertebral areas. And we'll talk about that when we talk about injury and vertebral artery injury, with the basilar artery that feeds that brainstem, but then again, the carotid arteries that go up to the middle cerebral and the anterior cerebral. So remembering our homunculus and the parts that are going to be affected with our middle cerebral artery and the anterior cerebral, and I'll show that in just a second here. Not going to go through all these details just yet, but this is very helpful, and the slides will be available to you on the website as well as on the app. So this is showing that where the areas of injury depending on the blood vessel. So the blue here, you see the anterior cerebral artery. These are the areas that if you had a stroke, you're going to lose, again, those motor, the leg functions, some of the frontal areas. So again, you might expect that personality may change. We look at that large gray area, that's the middle cerebral artery. So we lose a lot there. And the deep structures that are lost with the lenticular striates that come off the middle cerebral artery. So we can, just by looking at this, we could start guessing from knowing our neuroanatomy what lesions we would expect if we occlude a certain blood vessel. You can see that the the cerebellar arteries here are going to be affected here with the pica, and then the brainstem is going to be affected with basilar. So again, these are available for you to look at a little more closely. So the brainstem is another, when I talk to, again, families about what's going on, we talk about, especially if they're herniating, that the cortex is where, the upper part of the brain is where we do our thinking, where we initiate the ability to move things, but the brainstem is our way station. So it has, as we know, 3 areas, the midbrain, the pons, and the medulla, and knowing where your nuclei run through, again, will help you know where the lesion is without even looking at your MRI. So the midbrain is going to be the cranial nerves 3 through 4, and actually some of the 5th cranial nerve actually runs throughout the entire brainstem, even though most of it is in the pons. The pons goes from 5 to 8, and then medulla is the decussation of the pyramids, which, remember, the cortical spinal tract, our motor strength. And if you have a lesion above the medulla, if you have a lesion there, it's going to be the opposite side of the body you're going to lose. But if it's a lesion below that, it's going to be the ipsilateral side. And then the reticular formation. So if someone's not awake and you're evaluating your patient and they're sleepy, we know that either they've got a bihemispheric lesion or something's going on with their reticular formation, which is in the midbrain, dorsal midbrain, the central pons, and the anterior and central medulla. The ascending reticular activation is the wakefulness. The descending is postural imbalance. So the cranial nerves, and this is there for you just for reference, because I don't expect, and it's trying to get people not to necessarily memorize the exact names of it, but thinking as you're moving down. So we'll go through, in the neuro ICU, we don't check olfactory, but we do the optic and oculomotor. And then the other cranial nerves we'll talk about in just a minute as we move down here. And again, this is all here, and we'll go through these for a second. Because I like to think of it not so much memorizing as just moving your way down. Again, if you're thinking when you're doing your exam and you're not thinking, can I memorize the cranial nerves, but you're just moving your way physically down your brainstem, you can remember what you're going to do. So the vision, when we're doing this, we're looking to see, and we know that the optic tracks run so that they cross that, say something falls in our visual field on the left side. So this is in this side of the eye. It's falling on the retina here, and it moves to the optic radiations on this side. Whoops, sorry. And then if it's falling on this side, it's going to be falling on the retina on this side and then crossing across the optic chiasm. So we know that if we have a lesion in the temporal lobe, as you know, you're going to lose the entire the visual field in both eyes. Anything that's pre-chiasm, so before where the crossing is, it's going to be a problem with the eye itself. So if you're seeing that the problem is in one eye and it's not both eyes, then it's going to be pre-chiasm. If it's a lesion, so you're checking for visual fields, so that's why when we check visual fields, you cover one eye and see if they can mimic or see these fingers, cover the other and see it in that side, and that's how we're checking to see if it's both eyes or one eye. And when it's a temporal lobe, the optic tracts will turn around, and if it's temporal lobe, so if you have a patient who's had a temporal lobectomy for epilepsy, you're going to lose what we call the pie in the sky. So you're going to lose the things that are up in the opposite hemisphere in the temporal. If it were parietal loss, you would lose things down in this area, but the temporal lobe, think of pie in the sky loss because of the way that these optic radiations move. So we know that looking at pupils, and we're taught this very early, that we look to see if pupils are very small and reactive. Those may be narcotics. If they're very large, they may be that they've gotten epinephrine, an anticholinergic, or been on a lot of barbs. These tectal pupils, and people talk about hippus, and hippus is not always pathologic. Doing general medicine clinic and you're looking at young adults, sometimes you'll see hippus. So it doesn't necessarily mean that there's tectal injury. It can be normal, but it's important to watch to see if there's been a change. We think of these pontine pupils. So the difference between small reactive and pontine is that it's though you take a straight pin and poke it right through a little piece of paper. And to neurologists, when you say pinpoint pupils, I automatically think pontine. If you say small reactive pupils, I'm thinking of other things. Either they've got senile miosis, or they've had narcotics on board, but pontine pupils are pinpoint. When you see unilateral small pupils, this is something like this, where this pupil isn't necessarily dilated or fixed. Remember to think of whether the the pupil that may be abnormal is actually maybe the small pupil if the patient has ptosis, not in this particular picture, but because this one's unreactive. But if they're both reactive, think about Horner's as well. So that's sympathetic loss. The midbrain pupils are those mid-position fixed pupils, and we just talked the uncal herniation. We all know that when the third cranial nerve is compressed, and then the diencephalic pupils. So moving down, so we've done cranial nerve 2, so we've looked at the visual fields. Next, we're going to be seeing how they move their eyes. We know that the third cranial nerve, and if you've read Neuroanatomy Made Ridiculously Simple, the pillars of 3 hold that eye open. So if you just remember, 3 pillars will hold the eye open, and the hook of 7 will close the eyes. You'll remember that 7 will close. And then if you think of that, everything in the eye movement is 3, except the fact that lateral, so looking towards your ear. And if you're, again, visual, you think of the 6 here. It looks like an ear, so looking towards your ear is 6. And then your nose is like 4, looks like a 4, so that would be looking to your nose. Otherwise, all the rest is cranial nerve 3. The other thing that's really important, we'll get into this when we do those clinical vignettes, is eye deviation. So when you look at eye deviation, you should know exactly where you think is what's going on. But this is how it works, is that your frontal eye gaze center, so in this little cartoon, I want to drive the eyes to the left. So that means that the right frontal eye gaze center is firing off. That goes down, crosses over to the parapontine, so pontine, it's in the pons, reticular formation, and that goes up to the 6th cranial nerve to move the left eye laterally. This also goes up the MLF to the 3rd cranial nerve to move this eye medially. So you can imagine then if you're having a problem with either if the eyes deviate, so when you come to the patient's bedside and you're looking at them and their eyes are deviated, there's 3 choices that are happening if they're having conjugate deviation. 1, they're seizing on that right side, driving the eyes to the contralateral side, so looking to the left. So seizing here, or a stroke on the left side so they can't look to the right, so their eyes are deviated. Or a stroke down in the parapontine, or an injury down to the parapontine reticular formation on the opposite side. So the best way to think about it, again, either seizing on the right to look to the left, so contralateral side, or a stroke on the other side, or a stroke in the brainstem, or stroke or injury to the brainstem in the pons on that opposite side as well. And that's what's causing your eye deviation. So when we're looking at the patient, and we'll get into that vignette, we can figure out what's going on with their patient. Again, without calling the doc, without scanning the patient, you can figure it out also what's happening. So the 7th cranial nerve, as we work down our way, and actually, boy, did I miss 5? So I guess so 5, so 5 is obviously sensory, so we do corneal response for that, and then I don't know where, sorry about that. So 5 and 7, did I have it in here? Anyhow. Oh, I know, I had 3, 4, and 6 in here. Okay, so anyhow, so So 5 is going to be sensory, and then obviously you're going to look on the face for sensory, and also the corneal response will be the afferent of touching the eye very lightly with a cotton swab or with a drip. On the 7th cranial nerve, what we're looking for, there's a little bit of sensory to that, to the tongue, which we don't usually test in the external ear canal, but the most obviously is we know that 7, remember we close the eye with 7. The most important for you is when you're doing 7th cranial nerve exam, you have to also check whether when they lift their eyebrows, whether both eyebrows go up. The reason why in this patient you can see that there's no furrowing of the eyebrow, of the forehead here, this makes it a peripheral 7th, or it's either the 7th nerve from a Bell's palsy or the 7th nuclei, because there's bilateral innervation of the 7th nerve, of the 7th cranial nerve. So if you have a patient who has just, and you don't see it so well here, but there's flattening of the nasolabial fold with nice furrowing of the forehead here, then it's going to be a central 7th. So again, you can have the patient show the teeth, close their eyes, but you have to also have them raise their eyebrows. Some use the puffing the cheeks as well. And then the 11th is going to be the shoulder shrug, which we don't do a lot in the ICU, but the tongue as well as the hypoglossal is that, remember that the tongue, if it's weak, it's not going to protrude the tongue, so the tongue will deviate to the weak side. Now, if you have a patient who has a facial droop, it looks like their tongue deviates. So it's important when you have a patient with a pretty profound facial droop, you have to lift their face up and have them protrude their tongue, especially in a Bell's palsy. Oftentimes at the patient's facial droop, the ER doctor will call us and say, well, they also have a tongue deviation. I say, well, did you lift your the face up? And once they do that, the tongue looks midline. So again, if you have a significant facial weakness, you need to look and see if that problem is that there's a facial droop that looks like they're weak on one side. But again, remember that the tongue, when it's weak, the strong side's going to push the tongue out, the weak side's not moving, so the tongue will deviate to the opposite side. So again, so the very fast, and in the neuro ICU, I tell the nurses it's a very fast coma exam. We do the blink to threat, we look at the fundoscopic, we'll do to see if they have pupillar reaction. We use our light obviously and look for eye deviation. We'll do oculocephalic, so doll's eyes, and to see whether the patient is moving their eyes. Doll's eyes are when you move the head, the eyes should stay looking to one side or another. If all of you that are awake will not have doll's eyes response. So it's only when you're comatose that it's present, and and if you're fully awake, you're able to overcome that. So a lot of times we're not particularly using that in our usual exam for our nurses in the neuro ICU. And then we look for nystagmus. We'll do ice water calorics, where we put the head of the bed when we're doing brain death exam, the head of the bed, and when you're watching your physicians, or if you're doing as a nurse practitioner a brain death exam, make sure the head of bed is 30 degrees. You do 60 cc's of ice water in the ears when their tympanic membranes are intact, and you're looking to see whether the eyes deviate slowly to the cold ear and then fast cortex movement back, and that would be an intact oculocephalic ice water caloric response. And then corneal response we talked about, and then grimace, and then coughing to suction and gagging. So motor exam, we're looking at bulk, we're looking at some cogwheeling or Parkinsonian, we're looking especially in the ICU for any kind of myoclonus, which tells us that if the patient is post-anoxic injury, that's usually a bad prognostic indicator. Myoclonus, as opposed to the tonic-clonic movement we see, myoclonus is where it's arrhythmic jerking, and you can think of it as the cortex isn't good enough to mount responses that is synchronized, so it usually tells us, again, there's bad injury. We're looking for asymmetry and triple flexion response. So who knows what a triple flexion response is? It's pretty much no. So the triple flexion response, probably you're all shy, but you know that painful stimulus to the toe has a very primitive reflex, and the ankle flexes, the hip flex, knee flexes, and hip flexes. It looks like this. So it flips, and it looks exactly like this, and it's stereotyped. That's a spinal cord reflex. You could be brain dead and have a triple flexion response. So it's important when you're checking that to see that if the patient does that, you might actually grade that as withdrawal. What you need to do is pinch the inner aspect of the thigh and see if the leg moves away. That would make it a withdrawal then, or pinch the outer aspect, see if it moves in. That would make it a withdrawal. If it looks exactly the same and it's looking, when you pinch that toe and you have that triple flexion, again, it's a spinal cord reflex. So I warn patients, families, if the patient looks like they're brain dead, that the patient may move, but it's a reflex, because otherwise they're all excited because they think the patient's withdrawing and they're awake. So important to understand that. And sensory, in the coma exam, we're doing painful stimulus, looking for grimacing, facial movement, and motor response. Now for motor response, we know that the decorticate posturing, when there's injury that's above the red nucleus, the patient will do this decorticate or flexor response, and decerebrate is downward, and that means the injury is between the midbrain of the red nucleus and above the vestibular nucleus. It means that the patient is not brain dead, but it does mean that there's a lot of injury to the cortical spinal. And for reflexes, and I know this isn't something that typically we have our nurses doing, but hyperreflexive, if the patient's very hypertonic, we'll know that's usually an upper motor neuron lesion, and hyporeflexive usually is lower motor neuron. Paralytic medications also will make the patient areflexic. So something that I think that you'll hear later from Dr. Miles a little bit about more of the peripheral nerves. So respiratory patterns, again, something that you should be aware of when you're looking at patients. The Cheyne-Stokes, when you ask people where does Cheyne-Stokes come from, they almost automatically say it's brainstem, but it's actually not. It's bihemispheric lesion. When you see that patient take those rapid breaths, become apneic, rapid breaths, so there's usually bihemispheric injury. In the PONS, there's this central neurogenic hyperventilation, so those that work in the ICU will see patients that are hyperventilating no matter what you do with the ventilator. Your PCO2 is very low, not the normal 40, but almost as low as 15 sometimes, and that's because there's a pontine lesion. This apneustic is the cramped pause breathing, so they'll come in and very exaggerated, and that's a lower pontine. And then the ataxic or agonal breathing that unfortunately we're very familiar with, let's lower down, and then of course apnea, the lower injury of the brains, the medulla. So again, the quick cranial nerve exam, just to go through quick, we look at the visual fields, we count fingers. For us, we sometimes have them mimic fingers in the different visual fields. Cranial 2 and 3, we're looking at pupil reactivity with the light. 3, 4, and 6, we're having them move their eyes. We're also looking for ptosis. For the cranial nerve 3 and also for the Horner syndrome. Corneal response, when we're touching the cornea lightly, and the cornea is not the sclera. The cornea needs to be over the iris. We don't go, when you're checking it, we usually don't go over the pupil, because if you happen to, especially if you're using a little bit of cotton swab, and now we're using mostly saline drops, so this doesn't happen. We don't want to cause a corneal abrasion, but it's over the iris, not over the pupil, and certainly not over the sclera, which doesn't have corneal. And then facial sensation, touching, and the 3 areas of the face of the patient's fully awake. The facial droop, again, we're looking for any asymmetry when they're smiling, any kind of flattening of the nasal labial fold. We talked about shutting the eyes, making sure, again, they raise their forehead or raise their eyebrows. The oral pharyngeals 9 and 10, they're listening to their voice, how they sound like you're listening for that. We usually have them make the ga sound, ga, ka. Those are phonation sounds. Shoulder shrug and turning their head sometimes also to resistance, and then the tongue movement as we talked about before. I'm just going to make a quick mention about the peripheral and autonomic. I don't expect you to remember all this, but just remember, if your patient has had a paralytic medication, remember there's nicotinic receptors that are our somatic nervous system, so that's all our motor movement. That's what we're blocking with the neuromuscular blockading agents. The muscarinic are all the autonomic stuff that happens with our intestines moving and our blood vessels and our heart. So that's why the heart is working, the intestines are working when we give the neuromuscular blockading, but it's the nicotinic. So the one thing that you can examine on your exam when they've gotten a neuromuscular blockading agent, remember, they're not going to be able to move at all. The only thing is the pupillary response. So the pupillary response is muscarinic, otherwise everything else is gone. So it's important for you to know if they've had a paralytic on board, the only thing you're going to be able to examine on your patient are pupils until the patient gets their reflexes back. Not going to go through all this. This is in your handout, but just the spine as far as localization. Then we'll go into the vignettes. So knowing that we have 7 cervical vertebrae, but remember 8 levels, so 8 neurologic levels, but 7 spine. Then the 12 thoracic vertebrae and the 5 lumbar vertebrae. And we try and remember that, think of the spine as the bones. When you talk to someone, spine is bones, spinal cord is what is inside that spine that's protecting it. So the next is, when we're talking about injury, the most common, the neurologic or single neurologic level of injury is C5. So if we're counting it, this is the patient's DENS. This is 2, 3, 4, and 5. And this is normally where, well, not normally, but where the most common level of injury is going to be. This is again just showing some injury. And we have to worry about the blood vessels. Remember, the vertebral arteries run through there, so we have to think about those. And we know that there are blunt cerebral vascular injuries. So when you have patients who come in with cervical spine injury, think about if they look like they're having a stroke, you have to think that they might have injured their vessels, whether it's vertebral or it may be the carotids. There's screening that we do, and every center is a little bit different of what they use, whether there's a fracture through the bones themselves, like we see here, the foramen transversarium, facet dislocation, there's subluxation, there's basilar fractures, and if the patient has a stroke, we either use antiplatelets or anticoagulants. And then I mentioned again the nerves. There's 7 spine of the cervical spinal cord, spine, but there's 8 cervical levels here, and then 12 thoracic, 5 lumbar, and 5 sacral, and then the sensory as well as the motor. So one of the things hopefully you'll take away from this is your dermatomes. So if you can remember, and this is the fastest way, instead of pulling out a card, if you can remember this. So in the old days, the gun is a 6-shooter. So if you remember, this is a 6-shooter, cervical level 6, so C6. That means 7's below there, 8's below there, and 5 is above there. So 5 goes across here as the cape of C5. So there's a cape of C5, C6, 7 is here, 8, and then T1. So when you have a heart attack, remember that's some thoracic innervation. That's why you have pain that radiates down your arms as T1. So if you remember that, you don't have to go back and look at your charts. So 6-shooter. The other thing that if you remember then is 2 nipples we have 2 nipples, but if you remember 4 nipples instead of 2. So if you have 4 nipples, it's T4 at the nipple line, and it's like a tree, and it goes in and out. So if you're talking, so this would be T2, except for the cape that sometimes run along there, but at the notch here, sternal notch is T2, in, out is the nipples, that's 4, 6 at the xiphoid, that's in, 8 at the bottom of the rib cage, 10 at the belly button, and 12. So it's like an exercise, 2, 4, 6, 8, 10, and 12. So again, that would be an easy way to remember your thoracic levels. So 4 nipples instead, you start here, 2, 4 in xiphoid, 8 at the bottom of the rib cage, 10 at the belly button at the umbilicus, and 12 at the hips. And then if you remember a barber stripe, and this is L2, your finger here is 2, and you put it across your leg. So you can see here, so if my hand were here, it would be L2, L3 would be your hand going across here, L4, and 5 is going to be, the L5 is the lateral aspect of the foot here. So, so L5 is, the L5 is the toe, and S1 is the lateral aspect. So again, if you put your hand here, put it across here, L2, L3, L4. L5 runs laterally into your great toe, and the great toe is a pure L5, both motor and sensory, and then S1 runs on the side. So if you remember the great toe is L5, but remember the barber stripe. So 6-shooter, okay, 7, 8, and then the C5 here. Remember you're sort of in and out Christmas tree, so 2, 4 nipples, 6, 8, 10, 12, and then put your hand on your leg, and that's a barber stripe. Then you've got your dermatomes, you don't need any cards. Then as far as the motor exam goes, is that if you remember, well, 3, 4, 5 is the diaphragm, but the things that we use in the scale, the international standards for classification of injury, is if you remember your bicep, and again, this is going to be easy, so you're going to remember this exam without having to go to your cards. So C5, just like we talked about the brachial plexus, remember C5. C5 is your both the deltoid, but we check the bicep. So 5, 6 is the wrist back, okay, so you have the patient hold their wrist. 7 is the tricep, extending their arm. 8 is the claw, so the digiti profundus, so the finger here. Digiti minimi is T1. So again, 6, 7, 8 is going to be the arm extension. 7 is the arm extension, 8, and T1. So in the surgical ICU, they were just talking about recently, like it's a basketball throw. So it's like you're bringing the ball up, and then you're going to do the wrist back, and then you're going to extend your arm to throw the basketball, and then you do a yes, and then a high five. So that's their basketball way of remembering it. But again, it's a very quick, easy biceps. Okay, so C6, C5, C6, C7, C8, T1. You're done. That's it for your brachial plexus. And then for your leg, it's going to be very simple also. It's hard behind this podium, but so hip flexor, so it's just straight down the line. So bringing this leg up is L2. Okay, straighten the leg is L3, that's the quad. 4 is bringing the foot up. 5 is remember I told you the great toe is straight L5, so bringing the toe up. And then S1 is pointing the foot. You're done. So it's 2, 3, foot's 4, toe is 5, and then S1. And that's it. So now you can do your spinal cord exam very quickly that way. Okay, so we've done, that's the summary, and we're going to go into, in my last few minutes, hopefully the fun part of this. But just remember the exam starting at the top. You're starting with mental status, you work your way down the cranial nerves, we do motor, we do coordination, sensory, and gait. But in the ICU, we aren't walking the patients immediately. Then you think during the examination, you're thinking, where is the lesion? And then little tips to remember, motor forward, so you're going to be, the frontal cortex is motoring. Behind that, the post-central gyrus is going to be sensory. The nicotinic receptors are going to be what's blocked with your neuromuscular blockade, but the pupils work. And then your dermatome, 6-shooter, that Christmas tree in and out, and then the barber pole in the leg. So if you remember those, then you can get through this. Now we're going to get to the fun part. So where's the lesion, and what's the differential diagnosis? You guys ready? Okay, so our first is a 55-year-old right-handed man. So we're thinking left hemisphere dominant. He can't follow commands, but he's talking gibberish. It doesn't make a lot of sense. He's got a right hemiparesis, right field cut, and mild right hemihyposthesia. So where's the lesion? So we think that it's going to be in the left hemisphere, correct? And we know that he doesn't understand what we're saying, but he's putting a lot of words out. And I should have said that fluent word output probably has a lot of neologistic errors or whatnot. So he can't understand this, and it's probably going to be a left hemispheric, something that's happening in the temporal lobe, and that's the Wernicke's area. And so remembering that your differential diagnosis is something that happens acutely, and I apologize if some of you work more in the outpatient and you're looking at more neuromuscular things. You'll get that from Dr. Miles, but we're going to talk more about strokes. But the differential in an acute event like this is going to be either they've got a ischemic or hemorrhagic event that's happening in this temporal lobe here, or the differential could be that they had a seizure, and the seizure's gone, you never saw it, but the energy, the cortex is not working in that area, so it's acting like a stroke. So it could be like a Todd's paralysis and an ictal aphasia in a patient. So that's in the differential as well. So the next is a 78-year-old right-handed woman. So I made it easy again. Dominant hemisphere, no word output. Now, I'm not saying anything. Can understand everything you're saying, follows all verbal commands, and we're not cueing her. We have our hands at her side, and we're asking her to show 2 fingers or to stick out her tongue. She has a right hemiparesis, right hyposthesia. You guys all have this one, right? It's going to be a left hemisphere, frontal lobe, Broca's area, so it can be this area here, what it looks like. So again, in your differential, when you're thinking, as what you're going to do for imaging, you're probably going to need to find out whether there's a stroke going on. Again, same thing. It could be a Todd, not with the image that looks like this, but before you've gotten your imaging, it could again be another Todd's paralysis that's happening in that hemisphere. Okay, the case 3, 72. We have 8 cases to do. 72-year-old man who's fallen. He has a left gaze preference. Okay, so here we go, left gaze preference. So either he's seizing in the right hemisphere or had an event in the left hemisphere or event in the right brainstem in the pons. Okay, so now let's go to more of what we're going to examine him. Now we see his left side's jerking and shaking. So hey, that looks like a seizure probably. He's not following verbal commands, so he's probably ictal. He's not blinking to thread, again, he's ictal. He doesn't have any obvious facial weakness. That doesn't help us a little bit. Moving his arm or leg, sometimes if someone's having shivering or just sort of little clonic movements, if you move their limbs, it might stop, but this doesn't. So this is most likely a seizure. And it's coming out of the right hemisphere, right? Because their eyes are driven this way. It's positive phenomena, so it's not likely to be a stroke. It's more likely to be something like a seizure. And this patient ended up having actually a subdural that was causing seizures from that right hemisphere, causing that. So again, you could have localized where the lesion is and what you have to think about what was going on here. So a 70-year-old man who has decreased mental status. Now we have a left gaze preference again, okay? So now we're thinking left gaze preference. They're either seizing on that right hemisphere, got a stroke on that left, or stroke in the right brainstem. So now we see with the gaze preference, now they have a facial weakness, okay? So facial weakness that involves the forehead. Oh boy, okay, so that's either they've got a peripheral seventh, a Bell's palsy, which wouldn't make sense, or they've got something in the nuclei on that left side. And they have right arm numbness and weakness. So now what's happening probably is this patient has a parapontine or lesion, so something in the pons on this left side. Does that make sense? So, so their decreased mental status, the left gaze preference, the left facial weakness, and the right arm and leg weakness. So left brainstem, likely the pons involving that reticular formation, so they're a little sleepy. The left seventh nerve, the left cortical spinal tract causing the right side weakness. So that's before the decussation. The decussation happens in the medulla. So we could localize that to the brainstem. So this patient had a left brainstem lesion here. Okay, so the 21-year-old man fell off a balcony. He's awake, alert, following commands. He's got good strength in his bilateral deltoids. That's actually, that should be also biceps. So, so deltoids and biceps, so those are C5. The wrist extensor's working also, so C5, C6 bilaterally, but he's unable to extend his elbows. So that's 7. and he can't move his fingers or legs. So his sensory's decreased below 2. So going back to motor then, we could probably localize that to the fact that the last good motor area is C6, okay, so wrist extensor. And then the sensory's decreased on the thumb, on the second and third fingers on both sides and below both shoulders. So actually, I think I meant to say it was present on below, decreased below. I'm sorry. It's supposed to be decreased below, and the thumb, the second, third fingers, both sides are okay, but there's no rectal tone. So what that was is the motor level, like we said, was C6. The sensory level, so he had 2 and 3 present, and the thumb present. Everything below that was down. So again, if you go 6-shooter and 7, and below that there's nothing, then the sensory level is C7. So the way that we grade this by using the single neurologic level is the last normal level should be the motor level is actually a C6, and I did a typo in there. Sorry, KJ, I'll correct that. So this is an Asia A, meaning that the patient is completely absent with no rectal tone. They're totally out below that C7, but the last normal for us was C6. So the highest area of the last normal area, which is C6. So C7 sensory and C6 is sensory, but the last motor is C6. So that would make them a C6 level. Okay, so this patient, she's jumped off the wall at Waikiki head first. We see this often when they're jumping in the water. So 4 out of 5 strength movement in the biceps. So C5 is good, but flicker movements in the wrist extensor. So 6, the 7 is out. The finger intrinsics, including that the flexor profundus and the digiti minimi are out, and moving the lower extremities 4 out of 5. So she's weak in everything below the C5. She's got good rectal tone. So the motor level is going to be C5 because that's last normal. Sensory level, and I didn't put that there, sensory level is C5, but she has a central cord syndrome. So this is someone who has a C5 injury, and she does have rectal tone, so this puts her in what we call an Asia D, so where she has greater than 50% of the muscles below the single neurologic level of C5 is strong because she's moving her legs strongly. But again, the level is going to be the last normal level, that everything's normal, both sensory and motor are both normal. Case 7 is a 65-year-old with diabetes, hypertension, sudden onset of being lethargic. He's got a right gaze preference. So again, either seizing in the left hemisphere, a stroke in the right side, or a stroke or an injury and in the brainstem on the left side in the pons. Got a left facial droop. And then, so that's putting it, the left facial droop, so it's putting up in the right hemisphere, and then the pupils are equal. He's able to look bilaterally in a left hemiparesis. So now we've localized this, that it's going to be in the right hemisphere that this patient has probably had an event, because again, the left side is weak, and there's the gaze preference is going to be to that right side, so unable to look to the left, so the right side. So this patient had a right hemispheric lesion. Again, differentials, either a stroke until you get the image or a hemorrhage in this patient. And then the last case is a 66-year-old man who's diabetic, hypertensive, who's unresponsive. He's intubated in the field because he's found at home in bed. No medications that you hear. He's got no blink to threat. His pupils are small. They're pinpoint, so these are really tiny. And no corneals, no cough, and motor, no movement at all. And reflexes are present. So there's no paralytics on board because they've got reflex. We could think that the pupils are small due to medication, but they said that there's no medications, no narcotics. So we talked about the pupils being very small. And the problem is as we're doing our exam, there's one thing in this that I've missed. So, and that is the eye movements. Okay, so I didn't say it here, I didn't report it, but if you don't look at eye movements, you may miss this. This patient has slight eye movements to command, just a tiny bit of vertical gaze. And what this poor patient has is locked-in syndrome, where they've had a big pontine injury, pupils are small, and the only hint that you have that this patient's fully awake and aware and living a nightmare because he can't move, can't do anything, but fully awake, is that his eyes move. So very important in your examination to look at eye movements in these patients. And that concludes my part of the program. I appreciate you bearing with me with my little typos and errors. Thank you.